Welcome to the IFSO podcast. This podcast is sponsored by WeightWorks Clinics, the Netherlands.
Welcome to the IFSO European Chapter podcast. Today we are talking about the past, the present, and the future of bariatric and metabolic surgery. We're here together with Professor Jean-Marc Chevalier. I'll first introduce him. Professor Jean-Marc Chevalier was a professor of surgery at the Hôpital Européen Georges Pompidou, belonging to the Assistance Publique Hôpitaux de Paris, until his retirement. At the moment, he is acting as a consultant in bariatric treatment in a private clinic run by two of his former fellows. Jean-Marc was the co-founder of the French SOFCO MM, the Société Française et Francophone de Chirurgie l'Obésité et des Maladies Métaboliques in 1997. He was a member at large of the IFSO European chapter from 2018 until 2020 and was the recent president from 2021 till 2023 of the same IFSO European chapter, and of course is now the past president. Scientifically and clinically, Professor Chevalier had a lot of interests in severe obesity, minimally invasive laparoscopic surgery, gastrointestinal surgery, of course, the one anastomosis gastric bypass. His clinical portfolio, he has performed more than 8,500 bariatric procedures since 1994. Just to put it in perspective, I was 5 years old at that time. His research interests cover the pathophysiology of obesity, diabetes, related diseases, and of course outcomes of surgical procedures. He has authored more than 200 scientific papers, editorials, textbooks, video productions, and so on and so on. In other words, a colleague and a friend perfectly suited for this podcast to talk about the past, the present, and the future of bariatric surgery. Jean-Marc, bonjour. Welcome to this podcast. How are you doing today? How are you doing?
Good. Bonjour. Nice to be with you.
I'll first give you a very difficult question. I just listed a small part of your resume, a career spanning for more than 30 years. A question: what is, in your opinion, the most important part of history that put bariatric surgery or metabolic surgery on the map? What is the most important aspect that made it recognizable, that made it a main field in surgery as we now know it today?
When I began doing Mason and putting bands 30 years ago, like the other surgeons, I was quite lonely in my practice, and we had to convince our medical colleagues. Working in an academic center in Paris, I tried to collect the data and publish, and I had the pleasure to have the first paper in the Annals of Surgery, the first French paper. But, it was difficult because we were alone and, we were sure. We showed the results of the patients. We were much better, the weight loss, the quality of life much better. But we needed to convince, and the mainstream was the SOS study in 2004, which was published in New England and which helped us to convince our colleagues.
So basically the most important landmark is the SOS study from Sweden.
It was. It was, because it could help us. Because
and how did it change your practice from then on? Because in 2004 the first study was published. What kind of changes did you experience in your own practice in Paris?
We could work in a team. We could organize our team, because we could have the medical colleagues to work with us, which was absolutely necessary, because we did only the surgical procedure, and we had to follow the patient. And then afterwards, we saw, especially with the gastric band, that we needed to prepare. So prepare before, operate, and follow. We could not do the whole. We needed the medical staff to work with us. And that was the main, and we could convince them because of the SOS study at that time.
So as everybody knows, everybody experienced, the SOS study is the landmark study that generated the most evidence in our field, if I can state that correctly. And when we're looking at the past, Jean-Marc, of course, you're one influential figure on this planet. We had a lot more, of course. From your own personal view, which international colleague made the most impact on the field of bariatric and metabolic surgery?
In the United States, Kevin Higa and Alan Whitgrove created and developed the laparoscopic gastric bypass. Walter Porris was the first who published the results of the diabetes, the results of the gastric bypass on diabetes, because 10 days after the bypass, insulin was no longer necessary. It was the first. And Henry Buchwald did world surveys that were useful. In Europe, Joachim Perns with his technical skills, and Michel Suter with his very academic spirit, would say.
Yeah. So basically, you combined everything and put that to practice in France, if I may say so.
Well, practicing. You need. I didn't find any. Well, I have many friends in France that have been from the beginning putting bands with me 30 years ago. Jean-Pierre Marmuse, Jean-Marie Zimmermann, Jérôme Dargent in Lyon, still in. So we were 5 of us 30 years ago doing bariatric surgery in France only.
And nowadays the world changed. The world changed. You already pointed out a few influential figures. Walter Porris is of course one of them, and you're referring to that paper called "Who Would Have Thought It? Surgery as a Cure for Type 2 Diabetes." That's still an intriguing part, because nowadays we still do not have the answer. Just looking at the past and looking at right now, if a patient comes to you in your private clinic now with obesity and type 2 diabetes, how would you counsel, how would you prepare a patient for surgery, and what kind of surgical procedure would you recommend nowadays?
Every week I meet the patient and tell them the advantages and drawbacks of the different procedures. And I'm sorry, I apologize. I will say something very simple, but the take-home message I give to the patient is we can help you in 3 levels. First level is medical, diet, psychology, and now medication. Second level is an operation that can help you change your eating habits with a shrinking of the gastric volume by a band or a sleeve. But the problem is that we know with the band that if you operate too much, gastric wall will dilate, and there are 30 or 40% of failure because of eating errors. And the third step is an operation that can shrink the stomach and shrink the bowel, which is the bypass, but you will take lifelong vitamins. It's the take-home message, very simple, that I give to the patient. What do you need? Where are you? Just think of that to prepare, and we will help you the way which is necessary for you.
Okay. So basically, you're paraphrasing the core steps of losing weight, of improving your metabolic health, diet, a psychological aspect, an exercise aspect, and if that doesn't work, a surgical aspect. We can add as a 4th tier to this protocol. Did there were any changes in the last years, or do you still believe in these 3 or 4 simple steps for treating patients with obesity?
Well, the changes that happen is that now we have medication and endoscopy and surgery. We have three different ways to help the patients, which was not the case 30 years ago. We had the medical treatment. Well, why do we surgeons decided to create these bariatric procedures? It's because in 1996, the NIH said that obesity could be dangerous for life and shrink the life expectancy. And at that level, diet had an efficiency, transitory and insufficient. And for both reasons, we decided to create operation that could help the patient change their eating habits. So, and it was only surgery, and at that time the surgery was very dangerous with the bypass by open surgery. It was the only one that was done at that. And so now we can help the patient with medication because GLP-1 works and can help the patient being less hungry, so it works. Endoscopy can shrink the stomach. It is less invasive than surgery. And there is surgery. So that's the big difference nowadays, in my opinion.
And you're addressing two new treatment modalities: endoscopy, medication. Does that simplify treatment, or does it make it even more complex in your opinion? Because I can imagine, especially if you go to conferences, if you read a lot, it sometimes feels like a jungle. Like what was there?
What was for example, in France, which was in 2019 the third country in the number of bariatric procedures in the world, the 65,000 after United States and Brazil, because it was reimbursed by the national system. In that time, it was only 1% of the morbid obese patient that wanted surgery. So what does it mean? It means that most of the patients do not want so invasive treatment that surgery. So now that's the best because we have medication, we have endoscopy, and some of the patients will prefer to choose this less invasive way. And that's why it's absolutely necessary to work in a bariatric team and offer all this kind of surgery. Because as I say, if you can offer medical treatment, you will have more patients to operate. Cool.
So basically, with these new developments, we can tailor our approach on a more patient-oriented level. So we can give patient really a patient-centered approach based on what they need, based on their metabolic profile, on their comorbidities, and so on. Jean-Marc, I always wanted to ask you this question, and this podcast is the ideal moment. Where does your love for the one anastomosis gastric bypass come from? Because you've published a lot in the last few years.
Yes, well,
on that specific topic.
I began studying this operation in 2006, and well, why? Because I found it more simple than the rule. Why? Because of this only one anastomosis. And when I began, as I said, I was considered as a killer. So what was I did with the one anastomosis the same as I did in the past with the bending. So working in an academic hospital, I tried to follow the patient as much as possible and publish our data. And what was very interesting at that time was to do the experimental studies. We had the chance to be able to have a team doing this surgery on rats. And so it was even more interesting for academic center like ours to bring this information, because one week of a rat's life is 1 year of a human's life. So it could bring quicker answer to big questions. So it was even more interesting to do that. And that's why I was really, but it's my personal opinion, I was really convinced of the efficiency of this operation I saw with the patients. There's decrease their weight so much, quality of life, no pain, and so I was convinced, and I wanted the other to get convinced with really academic proofs.
So basically, your own clinical experience in this particular field with this particular operation, the one anastomosis gastric bypass, you substantiated it with papers, with clinical, with scientific evidence, just to confirm your own gut feeling, your own experience.
At that time, we had 450 bariatric procedures per year. So it was one operating room only dedicated to bariatric surgery. So it was very interesting to try to study new procedures like this one.
And you already mentioned at the start when you started investigating this technique, you were called a killer. Of course, nowadays, if you want to be game-changing, if you want to be innovative, you can sometimes get a lot of negative publicity, negative comments. How did you handle that in this particular case? Because it's really difficult.
Yeah, what's funny is the huge development of the sleeve gastrectomy, because it was a much easier procedure. Many surgeons did it, and without paying attention to the cancer risk in that field. But in the one anastomosis, we had to pay attention to that because we were considered as killer. But the question I ask to everyone is, why these experimental studies in rats that we did in the one anastomosis were not done in the sleeve gastrectomy? I mean, I don't know, but if in the sleeve gastrectomy there would have been these experimental studies showing that there are many Barrett's ulcers in the rats, would this operation be so distributed in the world or not? It's just one question. It's what I said to everyone. It's been unfair against the one anastomosis, and on the other hand, so positively for the sleeve gastrectomy. Both operations are good. Now we know that we must be cautious, do endoscopy before and follow with endoscopy afterwards, but not be so strict against one technique or another. I mean, if we have done that in the past, we would, for example, I work in an academic center, and when the sleeve began, I had to receive the leaks. And so I published a paper on 25 total gastrectomy on chronic leakage of the sleeve, because that's what we had. I remember a young boy, 24 years old, who had a leak during more than 1 year, and with a gastric fistula. He was about to die, and we had to. So all that I could have said, "Oh, stop the sleeve gastrectomy," but I did not say that. I say, "Well, go on, but be cautious." And now leaks is no longer a problem because it's been. So it's the history, and. I mean, all the procedures, the new procedures must be considered fairly. I mean, and not against one and for another one. I mean, all have advantages and drawback and must be chosen.
Yeah. So basically, you from your own clinical and scientifically point of view, you started studying one procedure. You started with experimental work, surgery on rats. Clinical studies, and that's one way to do it. And in terms of the sleeve gastrectomy, it basically went backwards because you've seen the detrimental complications it can have, and help those patients learn from it, publish it. For younger colleagues like me and many others around the world, if we want to have an innovative idea, how should we present that to the world? What's your opinion when we want to show the world our innovative idea? What would you do in our place when you have an idea and you
my advice for the future is, if you are interested in the bariatric field, work in a team. Do not stay alone, because if you stay alone, you won't be able to propose all the different solutions. So now there are medications, endoscopy, surgery. So first of all, get trained to the different bariatric procedures. I mean, you must be able. What's not good is what happens in some private practices in France, where there is only a sleeve gastrectomy, nothing else. A sleeve gastrectomy for a patient who is a sweet eater will not help at all, because the chocolate will go down like it in the past. So that's just an example. So every surgeon must be able to do different kind of procedure, restrictive and malabsorptive. Every bariatric surgeon must be able to do an anastomosis, which was not the case in the past. I mean, some say, well, I do sleeve because I don't know how to do an anastomosis. It's no longer possible. Every surgeon must get trained to anastomosis. And every surgeon must prepare the patient and follow them. It's impossible for the surgeon to do that. So he must be in a team with dietitians, nutritionists, psychological, and all of them must work together in order to prepare the patient, operate correctly, and follow them afterwards. In France, it's very interesting because I saw different periods of much enthusiasm after the gastric band. For example, many bands have been put from one week to another, and then the patients have been let in the world outside, no follow-up. And they say, well, the band doesn't work because they regain weight. And it's not the band who didn't work. It's the way it has been put, without preparation and without follow-up. It's the same now with the sleeve. In some practice, they just do the sleeve gastrectomy without preparation, without follow-up. It won't work also. They will say, oh, weight regain. Weight regain is because no follow-up and no preparation. So that's why young surgeons must work in a team.
That's some good advice from a titan in the field. When we look at the future, of course, young surgeons need to be trained, like you said. It's a multidisciplinary approach. Treatment of obesity is and will stay a multidisciplinary approach. We now have the development of course, medication, of course, endoscopy, newer surgical techniques. What's your vision of the future? How will the treatment of obesity further evolve in the next 10 years? What do you would like to see as a new development?
Yeah, well, it's a follow-up of what I said. I'm a bit concerned with all what is restrictive. I mean, what's just is to shrink the gastric pouch. Because if you do that, you must be sure that if the patient is not correctly accompanied, it will not work. That's what we've seen with the band, what we are now seeing it with the sleeve. They will re-eat too much and they will dilate the stomach. So that's really that must be understood, especially by surgeons. I know that in France there are simply speaking, two kinds of surgeons: those who are only interested in the surgical technique, and those who are interested by those who are interested by they are not interested in the results, so it will not work. In the bariatric surgery is not, it's not like cardiac surgery, or you can only do the operating technique. In bariatric surgery, you must be interested by the rest. So you must be interested by the patient. So you must be part of a bariatric team. It's my opinion.
So basically, teamwork will stay there, and will further evolve. And secondly, from a surgical point of view, it's not only the technique; it's also the physiology, the follow-up, complication management. So a more holistic approach of the surgical field, if I can summarize that correctly.
Yes, and especially for, complication field, the importance of the endoscopist, because now for the leakage of the sleeve, we now know that with the pigtail you can, which did not exist in the past. So you need an experienced endoscopist with you to work. It's an example, but it's really necessary, and it's not the endoscopy which will take part of the preparation and of the follow up. He will only be part of the complication treatment. So it's necessary to create a bariatric team as complete as possible.
Well, Mark, we can talk for hours and hours and hours. Because your knowledge is so immense. I would like to close off this podcast with a more personal question. You're retired now. Two things. You'll probably have more time to do hobbies and that kind of stuff. How are you going to spend your time? And secondly, what will you be missing the most from being an academic surgeon for over 30 years?
Sorry, I didn't understand the last.
What are you going to miss the most as of working as a surgeon?
Well, miss the most. Well, it's the meeting with the other friends. I mean, I like very much this IFSO meeting that we had years after years, when we can share our experiences. So probably, but well, the younger do not need the older one anymore. So it's not a problem. And the question is, what I will do has absolutely nothing to do with bariatric surgery, because I am painting. That's all.
So in the future, we will see a famous chevalier in a museum near you. Jean-Marc, I would like to close off this podcast. I would like to thank you for your knowledge and for joining us on this podcast. And thanks to our listeners, of course. And we will accompany you on the next podcast. Thank you very much.
This podcast was sponsored by WeightWorks Clinics, the Netherlands. Thank you all for listening.